Oops. Good afternoon or good morning, wherever you may be today. Welcome to today's webinar, hosted by the Global Institute for Simulation Training and Education Management Solutions. Our topic today is teaching trauma counseling in a CACREP graduate counseling program. And with us today is Dominique Avery. My name is Lori Kearns. I'm happy to facilitate today. Also assisting from EMS has been Chris Qualtieri and Glenn Willie. Thank you for joining us. Now, if this is your first time with us, welcome. And if you've been with us before, welcome back. Remember, you can close that control panel on the right side of your screen by clicking the orange button. And we do want your questions. Simply type them here in the question pane at any time during the webinar and click send. We will address as many questions as time allows. Thank you also for remaining in listen-only mode. For technical support, we have included the GoToWebinar support number here. If you're tweeting about today's experience, please use one of these hashtags. And yes, we are recording the webinar. You will receive a link to the recording and the slides from our office within the next few days. We ask also that you provide feedback following today's webinar by completing a brief survey. Now, please allow me to introduce you to today's guest expert. Dr. Avery first became interested in the field of counseling when she started work with children and adolescents in outdoor therapeutic settings. Her diverse background includes having started Forest Schools program with at-risk children in the woodlands of England, leading wilderness therapy groups in the deserts of Idaho, and caring for teens in an adolescent shelter home. Sounds very exciting. Most recently, her clinical passion has been with adult survivors of childhood sexual abuse, LGBTQ youth and young adults, and refugee children and their families. Dr. Avery is EMDR trained and holds additional certifications in traumatology from the International Association of Trauma Professionals. Please welcome Dr. Dominique Avery. And Dr. Avery, I am sending the presentation over to you right now.
Okay. Great. Is that all looking as it should?
Yes, it does. Looks great. Thank you.
Okay, great. Well, welcome everyone. I'm excited to be here today and sharing what is happening currently in the field of trauma counseling, as well as allied disciplines, traumatology, psychology, and social work, and looking specifically at what are the implications for teaching trauma counseling within a CACREP graduate program that's aligned with the 2016 or 2019 or 2009 standards. So I want to start off with this quote by Judith Herman that really speaks to the evolution of the field of traumatology, and it's received extensive advancements and attention in the last 2 decades. And so within counseling, trauma counseling has become rather ubiquitous, but yet we still have relatively little information as to how this is being addressed within counseling programs. So whereas before trauma wasn't necessarily addressed within counseling, now we're not sure exactly how it's being addressed within the training of our next generation of trauma counselors or trauma-informed counselors. So I first came to this topic from my own personal experience in my master's program. I was in my program at a time when the program standards were being redeveloped and reorganized, and a crisis and trauma class was introduced for the first time. This was not a requirement for myself in my master's program, but I was able to take it as an elective. And that, coupled with my internship experience focusing on working with trauma survivors, I noticed a dramatic difference between myself and others who had taken the class or had a trauma-focused internship in terms of comfort level with working with trauma, comfort about talking about trauma, and general awareness of the impact and prevalence of trauma within our client caseloads. And then this coupled with the emergence, like I spoke before, about traumatology as a discipline that's now, there's now numerous ways to become certified, have additional trainings, postgraduate. So we're looking specifically at what is happening within the graduate level program, so entry-level professionals who may or may not have done any of those postgraduate or supplementary trainings. So the CACREP standards first introduced the need for trauma within the 2009 standards. And this emerged out of a accumulation of results. Beginning in the 21st century, we had the 911 disaster, and then we also had two major hurricanes back to back. And so this renewed a focus on specifically the need for crisis and disaster and trauma training within our helping professionals. There was a high need for immediate response, and thus looking at how are we training people to provide this response. And then this isn't unique among counseling. We also have the field of psychology and social work have a parallel process in developing training standards. So if we within counseling are staying current and staying up to date with the latest research and emerging trends in the helping allied disciplines, then it really is important for us to be aware of what's happening within our partner organizations and stay current with them as well. So we're just going to pause here and take a quick poll.
Okay.
Yeah.
I'm going to go ahead and launch those polls now. Go ahead.
Okay, great. Yeah, so I would like to know, first of all, how have you taught trauma counseling, if you have at all? And then also, how many years experience do you have teaching trauma counseling?
Okay, so Dr. Avery, this first poll is open and the results are coming in. And I can tell you that in the lead is not at all. So we've got a really good audience with us today. And in fact, let me share those results. So of our audience members, a full 55% are saying they haven't taught trauma counseling at all. 29% are saying it's infused in the curriculum. And 16% are saying as a standalone course. Now, the next poll question that you wanted to ask, let me launch that now. And that is, how long have you taught trauma counseling? And as we know, many said that they had not. So as expected, that's in the lead right now, followed closely by 1 to 3 years. So I'll give just another couple of seconds for our audience. And it looks like those results are in. And 66%, Dr. Avery, are saying 0 years. 20% are saying 1 to 3, and then single digits for the remaining options.
Okay, thank you.
We are back to the slides.
Okay, yeah, so that actually is what I would expect across the field. By far and large, this is not being addressed as a focused area of intentional training within programs. So let's take a quick look at what is happening within the 2016 CACREP standards. So there's a few places in which the need for crisis, disaster, and trauma training is specifically addressed. One is in the human growth and development and looking at the effects of those on individuals across the lifespan. The next is in counseling and helping relationships. And this is looking specifically at community-based strategies such as psychological first aid and other interventions. Within assessment and testing, there's procedures for identifying trauma and abuse as well as reporting abuse. So that's related specifically to trauma. And then within the specialty areas, clinical mental health counseling, there's a need for knowledge on the impact of crisis and trauma on individuals with mental health diagnoses. Within clinical rehab counseling, we're looking specifically on the impact of individuals with disabilities. And then marriage, couple, and family counseling, again, looking at the impact of marriage on marriage, couples, and families. Not surprising, there's no direct reference to the need for knowledge of these areas in career counseling, school counseling, or college and student affairs. There is a standard that includes knowledge of the roles in relationship to emergency management plans, as well as crisis, disaster, and trauma. So it's more that administration level of what is your role within the system. At least that's how I interpret the standard. And then the unfortunate part here is that there's no mention of a need for knowledge related to the diction standards. And I see this as a great oversight within the CACREP standards, because by far and large, the research shows that counseling within this area has a high instance of co-occurring disorders. So one study from Bright and al. Showed that 97% of counselors who are working with substance abuse, their clients have a caseload with identified trauma issues. So nearly everybody who is working within substance abuse is going to see a client at some point with issues specifically related to trauma. And as you see here within the CACREP standards, there's a grouping of crisis, disasters, and trauma altogether. And I think it's really important to pay attention to how these are similar and how these are different, because there are some really important distinctions when we come down to how we're addressing these within the training of counselors. So with disaster, I like this definition from Hillman that says that disaster may be described as a sudden and catastrophic event that causes widespread loss of life and or destruction. So looking at the emergent time-limited situations of a shared catastrophic experience. And then this is different from crisis in that somebody who's experienced a disaster might have a crisis, but it's not necessarily pertaining to those big catastrophic events. It could be a developmental crisis. It could also be a common situation in which someone, because of other undue stresses, is no longer able to access their previous coping skills. So this definition from Cannell breaks crisis into 4 parts. So there must be a precipitating event. It's specifically the perception of the event that a person views as threatening or damaging. And then it must lead to emotional distress in order for it to be considered a crisis. And lastly, that emotional damage leads to an impairment of functioning in which individuals' previous coping mechanisms are preventing them from being able to function appropriately. And within crisis treatment, really the focus is not so much on processing or lasting effects, but it's focused on that time-limited situation of being able to restore a person to their previous functioning, either from reinvigorating previous coping skills or helping to build and instill new coping skills. So this is different from disaster and crisis, are different from trauma, as well as related in that it is that immediate response. They can lead to trauma, which defining trauma actually is quite a challenge, because there are so many different definitions out there and so many different perspectives on what trauma is. I've chosen to focus on the SAMHSA definition here due to its grounding in research. And SAMHSA convened a panel of experts that reviewed a full inventory of definitions throughout the field. And they wanted to generate one that was specifically relevant to public health agencies and service systems, so working with the greatest number of people possible. And in their review, SAMHSA they were able to distill trauma definitions as having 3 critical components. One is the event, the other was the individual's experience of the event, and then there's the adverse effects as a result of it. So SAMHSA defines trauma as resulting from an experience, series of events, or set of circumstances that is experienced by the individual as physical or emotionally harmful or life-threatening and has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So the key thing here is not so much of what type of event it was or what the specifics of that is, but rather on the perception of the individual and the impact it has for them going forward. So that is the key that really defines and distinguishes trauma from crisis and disaster. I also want to add in here that part of the American Counseling Association's definition that I think elaborates a little bit more on that lasting effects from the perception of the individual. So this includes that on the psychological level and emotional level, a person's spirit and sometimes the will to live, as well as beliefs about the world and oneself, dignity, sense of security, thinking, and feeling have all been impacted, and that their usual ways of handling stress become inadequate. So this speaks to the persistence of trauma. And those of you who are familiar with the DSM-5 definition of and criteria for PTSD will know that what we define as trauma, this sense of symptoms, may not emerge immediately after the result, the event. So it can be a delayed result. It can, and the impact persists in the person's life for years, and sometimes only emerges years later. So being able to tease out trauma as something that we need to focus on specifically, because it does have such lasting results, and can the impact that we see within treating clients may not be connected specifically to the event. We might see the person months or years afterwards. So it's important for our students to be aware of how this impacts a person, as well as being able to do adequate assessment and asking about trauma histories. So we're going to move into what is happening within the field. And first of all, I want to visit the field of traumatology, which is an interdisciplinary field. So it's quite extensive. There's a huge number of organizations out there who are providing either direct trauma treatment, doing international relief, providing trainings and certifications and postgraduate knowledge and skill work for clinicians. I've chosen here to focus specifically on the traumatology organizations that have offered specific sets of guidelines for trauma training. And the reason why I've done this is because this is related to my dissertation research, in which I was looking at what are the specific guidelines that are out there for training clinicians or training entry-level professionals in that counselor and training level. And how can we go about beginning to bring those into the field of counseling? So there's a lot of organizations that offer certificates and training, but don't specifically offer those sets of guidelines, and I've chosen to exclude those for the time being. So the first of this is the International Society for Traumatic Stress Studies. And they have a set of 18 guidelines that are drawn from evidence-based research in the field. And these include a whole way of working with individuals, couples, and families, as well as children and adolescents. Some of these guidelines include psychological debriefing, talking about where and when that is appropriate and when it is not specifically. Psychological behavioral therapy, psychopharmacology related to trauma and traumatic stress, eye movement desensitization reprocessing, or EMDR, group therapy, school-based treatment, psychodynamic therapy, psychosocial rehab, effectiveness in hypnosis and other creative therapies and arts. So within all of these different guidelines, they have specifically drawn recommendations for those that are deemed clinically important. And they define clinically important as having the aspects of quality research that actually connect these to practice and show the efficacy of these practices. So random clinical trials are important here, as well as outcome measures, magnitude of change, effect size. So looking at really what is the research showing on the effectiveness of each of these treatments. And then another important organization that has done a lot of work in this area is the National Child Traumatic Stress Network. They've developed a series of 40 evidence-based treatments. So really drawn together a lot of what is happening within the field, what are all the different approaches that are being used. And then in addition to this, they've developed their own set of guidelines, and these are housed under the umbrella of the core curriculum of on childhood trauma. And this is an extensive curriculum that's been used within social work. It's used within clinical psychology. I couldn't find any information of its use within counseling training, but it's also used in other allied health professionals and those who work with clients who've experienced trauma in the field of traumatology. Within this, they've developed a set of 12 core concepts for understanding traumatic stress. And these are specifically looking at the impact of traumatic stress on children and their systems, so their families, their schools, and how the children are functioning, including the developmental impact of trauma, chronic traumatic stress, and specifically how this affects children uniquely. There's been some research on the use of this curriculum, mostly within the field of social work. It's been found to be effective in increasing student self-efficacy while approaching and treating trauma. If you're interested in finding out more, it actually is available as a free online course through the National Child Traumatic Stress Network. So they've made it readily available to all helping professionals. But really the key here is that I'm drawing from is those 12 core concepts. So what are the base knowledge of skills and knowledge that are required for treating children who have experienced traumatic stress? So as we said, this core curriculum on childhood trauma has been used extensively within social work. Part of the reason they've adopted this is that the Council on Social Work Education has had a call out for the inclusion of trauma training within social work graduate programs, as well as undergraduate education. And this is because there's a high rate of exposure among professionals who are working with their specific populations within social work. Many clinicians, many of the social work professionals are exposed to individuals and families and their systems that have had sometimes quite complex and ongoing traumatic experiences, as well as chronic and systemic trauma. So there's really an ethical need for the field of social work has identified in being able to train their professionals in dealing with this work, providing them with resilience factors to prevent against vicarious trauma and secondary traumatic stress. And really looking at that duty as coming from the graduate level to build that foundation before they're sending professionals out to work with their populations. There's also a call for research on training models in here. So they've adopted that core curriculum on childhood traumatic stress. There's been a few studies that have emerged out of that, looking specifically, and we'll look at that in the next slide, looking at what that does and how that is effective within training in social work. But first of all, the Advanced Social Work Practice in Trauma is a document that has been developed from the Council of Social Work Education to be able to provide some training guidelines. And they take a trauma-informed approach that trauma is not just a specialty field area, but it's something that all professionals within social work need to have a baseline level training with it. And it includes 10 competencies that outline skills and knowledge required of that trauma-informed approach. So some of the research that's been done in this came from Abrams and Shapiro, looking at that evidence-based, case-based approach. And this is looking at the adoption of basic trauma treatment concepts. So some of these include creating safety, co-creating the therapeutic relationship, enhancing self-efficacy, being able to provide psychoeducation about trauma to clients, increasing affect regulation, of the clients, but then also that personal awareness of monitoring yourself for vicarious trauma, secondary traumatic stress, being able to manage personal reactions when working in this situation, as well as increasing affect regulation in the clients, instilling hope, being able to do future planning, develop interpersonal skills, expressing emotions, and lastly, there's a need for awareness of cultural differences. So this has been implemented specifically for one intent of compensating for any potential inconsistencies that may be occurring in field placements. So like I spoke to my own experience that there might be people who are placed in an instance where they get a lot of support from their internship site and they get a lot of additional training on trauma skills and knowledge and applying that work with their client populations. And then there might be others where they don't see a lot of clients with trauma, or their supervision isn't trauma focused. So being able to provide that graduate education to be able to provide that foundational knowledge for everybody across the graduate program. So one set of research on this used a pre and post test design, and this is Lane et al. Has done various studies and found that the use of the core curriculum on childhood trauma has an increase in reported confidence from students, greater feelings of readiness for field work, greater awareness of trauma-related knowledge, as well as increased reasoning and clinical judgment that take place much faster than didactic course training alone. So that evidence-based, case-based approach is really important in being able to provide students the opportunities to integrate and apply that knowledge. And then here in the field of social work, or sorry, moving from social work, we're moving to psychology. And the, first of all, psychology has a similar experience of coming about this along the same trajectory as counseling and social work. And they've also advocated for the inclusion of basic information about trauma throughout their entire curriculum, beginning at the undergraduate level, including coursework, at the graduate level, practicum, internship, and future supervision. So to do this, they've convened a panel of 60 experts that's called the New Haven Trauma Competency Group. And this group has made the statement that most psychologists only have the cursory knowledge of this science and no formal training, nor apply evidence-based psychosocial treatments for trauma-related disorders. So there's a lot of psychologists who are out there who are seeing trauma in their caseload and yet don't necessarily have that foundational level trauma-informed knowledge unless they've sought that out postgraduate work. So to address this deficiency, psychology has developed an APA set of guidelines that are for entry-level standards, and these were just published in 2015, so they're very recent. They include 46 competencies that include a variety of skills, knowledge, and attitudes related to working with trauma. And they're intended to create those minimal level standards. So for entry level psychologists, this isn't any advanced level trauma specific training. This is trauma informed approach of everybody who's entering the field. And some of these focus on areas such as scientific knowledge about trauma, psychological trauma-focused assessment, trauma-focused psychological interventions, trauma-focused professionalism, and trauma-informed relational and systems approaches. So let's move on and look at what's happening within the field of counseling. The American Mental Health Counseling Association has recommended additional training in the area of trauma, and they say that the treatment of trauma and chronic traumatic stress or distress is essential for practice of clinical mental health. So they see it as that core component for clinicians working in mental health. They have developed a set of guidelines. However, within these guidelines for trauma training, because they're looking at clinical mental health professionals, those are typically defined as somebody who has 3,000 postgraduate hours in clinical experience. So it's unclear as to whether this training is intended for postgraduate professionals, or whether this is appropriate for counselors in training in that pre-entry level graduate studies. So some of the content that they recognize within knowledge is the type of context of trauma, how trauma events affect the individual, distinctions and impacts of different types of trauma, the long-term consequences, resiliency factors. They also focus on the application of theories as well as approaches of working specifically with child and adolescents and how those differ from working with adults. Additional skills that they include is being sensitive to factors in treatment planning related to trauma, and being able to recognize the impact of personal trauma on your own counseling abilities. So there's that self-awareness piece of being able to do that work before working with clients so that you're effective. There's also a skills approach of being able to develop treatment interventions for developmental and chronic traumas. So working again with childhood trauma, such as the core curriculum on childhood trauma that we saw from the National Traumatic Stress Network. And then lastly, SAMHSA has two sets of guidelines. One is the SAMHSA's concept of trauma and guidance for the trauma-informed approach. The other one is the trauma-informed care and behavioral health services. And this is a quick guide that's actually my favorite go-to as a starting point with students or with professionals that I see in supervision. So this does a really nice job outlining the principles, tools, approaches that are necessary for a trauma-informed approach. It's very approachable, it's very readable, it's available for free on their website. So if you don't have a lot of familiar with trauma-informed approach or how to actually implement some of this training, it's a really nice entry point. And some of the keys here is that SAMHSA advocates for educating all professionals to be trauma-informed. However, they do make a very specific caveat that professionals use their trauma-informed knowledge to be able to recognize if a client is more high risk and needs some of that really specific advanced level training for treatment of trauma-related disorders. So they're not advocating that every clinician be a trauma clinician. They're advocating that every clinician be trauma-informed and being able to work within the bounds of your own competency. So we're going to pause here and do one more poll. Yeah, for those of you who are working within the field of graduate work, where is trauma training offered within your program's curriculum?
And I have opened that poll for you, and the results are coming in. And while we're waiting on those results, I do have one clarifying question from Lisa. She asked specifically about the NCTSN that you mentioned and wondered if it was Canadian.
Oh, no, I believe that is a US-based organization, but many of these traumatology organizations have a wide purview of international work as well. So to the best of my knowledge, it's US-based, but they might also do quite a bit of work in Canada.
Thank you for that. Now, the results are in, and I'm sharing those results now. And I can say that in the lead is before practicum with 41% of our audience members responding. And then second with 34% is not taught as a standalone course. And then the small double digits for the rest during practicum and during internship.
Okay, thank you.
And we are back to your slides.
Great. Yeah, so let's look at reflecting what the results of that poll of where is trauma counseling being addressed within counselor education and supervision. So that's great to hear that the majority of those who are teaching it, that it's happening before practicum. When I did my dissertation research, So in the summer of 2016, I reviewed all the currently accredited CACREP programs and looked at their programs of study to see who was offering a trauma-specific course. So how I defined that was a course with trauma in the title. And I found that only 23% of CACREP programs included that on their program of study. So that might have meant that they're infusing trauma standards throughout the entire curriculum rather than teaching a trauma-specific course, but without knowing those details, it's really hard to get a grasp on exactly how this is being taught. This also parallels some recent research that did a similar process of reviewing CACREP programs and found that only 29.4% were offering a standalone course in crisis intervention. And of these courses, some of these addressed trauma work as well. So 20% added just trauma work. Another 5.2% added trauma and disaster counseling to that coursework. And then another 4.2% added trauma and grief counseling to those crisis courses as well. And then this is further supported by a survey that was done of National Association of Alcohol and Drug Addictions Counselors, and they found that only 39% of their members had taken academic coursework within their graduate programs related to crisis and trauma. They did find that 82% of respondents were going on and after graduation we're getting education in trauma treatment for postgraduate continuing education. So even though it's not being addressed, the majority of people are finding it necessary enough through their experience with clients that they're seeking out that training themselves. And then another study found that, by Stuart Spencer and Brown, found that 79% of counseling programs did not require a standalone course in trauma. So this was published in 2015. So it looks like the numbers have gotten a little bit better when I did the survey last year, but by far and large, it's not being addressed as a focused area of training. And similar to the study on the NAADAC, they found that 94.7% of counselors in training were interested in taking a course exclusively on trauma if it was offered within their graduate program. So I know we get into that sort of tough area of there's so many topics that yes, it would be nice to include a specific course in this area, but within the field of trauma counseling, the research is showing that students identify this as a specific need that needs to be prioritized within graduate training. So, and part of this stems from the fact that one research study from Adams and Riggs found that a quarter of students were working with clients with trauma histories without first receiving any training on trauma topics. And further, they go on to further elaborate and saying that a full semester course or multiple intensive workshops may be the best option of protecting counselors in training against vicarious trauma, because those who had not received any trauma training or had minimal trauma training were much more vulnerable to vicarious trauma within their internships, and then extrapolating, they would be going further on to postgraduate work with clients as well. An older study by Kitzrow found that 60% of counselors believe that training for work with clients who've been sexually abused is very important. Of the remaining participants who were surveyed, another 35% found that rated it as important, and 5% rated it as somewhat important. So just about 100% of counselors in that survey said that there was some degree of importance of having specific training and working with clients who are sexually abused. And then some of the studies that have been done looking at what are the benefits to students as a response to doing this training. For those who have received suicide response training, students report lower anxiety and higher confidence when encountering a situation with a client with suicidal ideation. A master's level counseling course in crisis counseling results in feelings of higher preparation and greater crisis self-efficacy of students. And like we spoke about before, drug and alcohol counselors who had not received trauma training have gone on to actively seek this out postgraduate education. One study found that among the participants who were surveyed, they stated the most important aspects of trauma training are how to treat trauma, how the use of coping skills, as well as the effects of trauma on the client. So those are what they're viewing as priorities. If we're looking at an already packed curriculum, where are we going to focus our time? So this led to the research that I did of looking at, we already have a very full curriculum, and even though this has been shown in limited research to be a benefit, where are we going to focus? So I used a methodology called Q methodology. That's an exploratory methodology that blends both quantitative and qualitative aspects. And I asked the question, what do counselor educators believe is the most important aspects within trauma courses for counselors in training? And to do this, I generated 2 sets of statements from those guidelines that we reviewed earlier. One was a set of knowledge statements containing 16 items. The other was a set of skill statements containing 23 items. And I asked participants to rank order these according to what is of highest priority and what is of lowest priority when we're really focusing on some limited time within the counselor graduate program, and also that the scope of traumatology is quite vast. So we're not training all our students to be trauma-specific counselors. We just don't have time for that. But what do we need to include in order to have trauma-informed entry-level clinicians? So of my participants, I had 11 that all were identified as having some expertise in trauma, and this was defined as either having taught a trauma-focused course or had published on the topic of trauma specifically within peer-reviewed literature. So by far and large, it was a fairly homogeneous population. Most were female, most were white. There was an average age of 48.6 years. Of my participants, I had 11, which is in line with the recommendations for my methodology. 5 were trained in counselor education and supervision. All of these were working within counselor education and supervision, but 5 had degrees specifically in that. Another 3 had PhDs in clinical or counseling psychology, and then 1 was an unspecified PhD, 1 was a doctoral candidate, and 1 had an unspecified master's degree. So all were teaching at programs that were aligned or accredited under the 2009 or 2016 CACREP standards. The participants had an average of 4.2 semesters teaching trauma. The range was from 1 semester to the equivalent of 14 quarters, which is 9.3 semesters. And 1 participant had limited experience as a trauma counselor, but the other 10 participants had quite extensive experience of providing trauma counseling. There was an average of 20.8 years, and that ranged all the way up to 30 years of experience in the field. And of the 11 participants, 7 had published on trauma-related topics in the field, so they've identified this as an area of research, area of interest beyond teaching in the classroom. So what I found through factor analysis was there were 3 factors emerging that each represents a shared perspective of a group of the participants. So within the knowledge set of statements, there was one perspective that the holistic systemic aspects of trauma training are the most important. So the focus on this is to destigmatize the effects of trauma and really viewing the individual and the trauma experience from that holistic systemic perspective. So looking with them within the system, within the contextual aspect of trauma. And then on the other side of this, participants rated aspects related to neurobiology and psychopharmacology as lower priorities. And some of the rationales for this included that it was less critical and doing no harm during clinical practice to have that knowledge, as well as this knowledge is things that could be acquired postgraduate quite easily, and therefore wasn't a priority of focusing on that within graduate training. One participant, I have a quote here from in providing some of that qualitative data for why this holistic and systemic perspective is most important, said that counselors and counselor educators need to understand the manner in which contextual factors, including racism and oppression, impact the individual. Historically, I would contend that psychologists and counselors have focused on the neurobiological symptoms of trauma and neglected the contextual factors. Trauma impacts different dimensions of the individual in order to explore the trauma response holistically. So looking at distinguishing ourselves from psychologists and bringing that holistic wellness perspective is very important to our identity as counselors within this shared group of individual or participants. So then within skills, there was a very similar perspective that emerged. This is, I called it the client-focused strengths perspective, and this is characterized from a client-centered approach. So there's also in this a need to be culturally sensitive, focusing on the skills that provide that strength-based approach of working with the client, as well as one that empowers the client. And then conversely with this, the skills that were viewed as lower importance for focus within graduate training is the ability to ask about trauma exposure and reprocess traumatic memories. So a couple quotes here from participants. They said, I also believe that counselors need to attend to socio-cultural factors when using trauma treatment approaches. Cultural competence is a prerequisite for effective trauma treatment. And then another participant provided the comment that building trust and using a strengths-based approach are two important tenets of the foundation of counseling. Trauma treatment inherently requires a tremendous level of trust on part of the client because often their trust has been violated in the past. So looking at ways that we can actually work with the client to be in charge of their own journey, and those are the skills that this group of participants found to be most important. Another shared perspective that emerged from this research is a practice-focused perspective, and this is looking specifically at the knowledge for trauma-informed counseling and the use of evidence-based practices. They differed very much from the previous perspective in that they viewed the context of trauma as lower importance. And some of the rationales for that included that counselors could be effective without this knowledge. And another participant commented that although it's helpful to know, it does not directly relate to treatment. So they're looking very much more on what are you doing in the room, what knowledge do you need for that, and then how can we view that within the evidence-based practice. One of the factors, or one of the aspects of this factor that emerged is that the use of evidence-based practice is an ethical obligation. So one quote here from a participant, it says, having the skills to actually do the work with the survivor is most important. And many counselors are able to conceptualize, but not actually able to do good work. So evidence-based strategies are a must. And then similarly with skills, this effective practice perspective, and one participant commented that the ability to teach a client about the impact of trauma and provide appropriate evidence-based practice is absolutely critical, and that clinicians also need to watch for the impact of treatment and make adjustments throughout, since trauma treatment in and of itself can do harm. And I think this is really important to recognize that it's one of the tenets of our code of ethics is to do no harm, to monitor ourselves for effective practice. So without providing our students with direct knowledge of how to approach their clients from a trauma-informed perspective, we're potentially sending them into situations where they could do harm if we have a client with extensive trauma history. And then the last factor which emerged, the shared perspective here, is that there's a subjective experience. So the importance of neurobiology, knowledge of neurobiology was important, grief and loss, and the subjective response. And conversely, with the previous perspective, these participants viewed the evidence-based intervention was less important. And one participant provided the rationale with this of just because an intervention is considered evidence-based, it does not prioritize it over other interventions that do not have good empirical evidence. So there's some of that reaction against what is deemed an evidence-based. Sometimes it comes in the form of a manualized treatment. So being able to work with the client and approach them effectively is the most important aspect for these participants. And then skills, this is mirrored with that self-awareness. So participants who had this perspective focused on knowing the impact of one's own history, values, and vulnerabilities as being one of the most important priorities. And some of the rationale for this was that before striving to do trauma counseling, which this participant viewed as a specialization, that's not necessarily appropriate for every counselor. And the first imperative for this participant is to do no harm. So having that self-awareness, being able to recognize where that is within the approaching clients is most important. So I want to provide a little bit of context of how these are related to each other. We can see factor one here has some of that client-focused social historical contexts. And this is really a unique perspective separate from the other two. There is some overlap with the subjective experience, that third perspective that we talked about, in that they're both client-focused, but it really is a separate and unique perspective from the second one, which is the importance of neurobiology, the evidence-based approaches, knowing scope of practice, having those trauma-informed skills. And then I want to bring attention to this area in the middle. So these are consensus statements across all of the different perspectives. So if we're looking at, okay, so where are we going to come from? What approach are we going to take? These are shared values of what are priorities that we need to be looking at. And some of those include the developmental impact of trauma, establishing safety, knowledge of the types and contexts, being able to recognize one's own limits, empower clients, understand the complexity of trauma, all those legal ethical issues related to trauma. So that those can be some of the core areas at which we focus. And that's seen in these priorities across all these perspectives of what is most important, such as the ones that we just mentioned. And then if we have limited time, this is really where we can focus our training of counselors at the graduate level. And then if there's additional time, we can include more knowledge of the types and symptoms and reactions to trauma, as well as greater knowledge on the impact of the domains of functioning. And by far and large, knowledge of psychopharmacology and specific modalities of being able to do that skills reprocessing were seen as least important within that entry-level graduate training. Having that broad trauma-informed scope knowledge and skills was much more important. So some of the recommendations that I have here is that all graduate level counselor and training programs should offer a trauma-specific course, as well as infuse it throughout the curriculum. And this was a shared perspective amongst all my participants, and that there really is a need to develop competencies, both for entry-level trauma-informed graduate training competencies, and then being able to distinguish that from the advanced level postgraduate trauma counseling competencies. So if somebody is to get that additional training and specialization area, how is that different from the entry-level competencies? And we don't have clear evidence to or research to provide that distinction yet. So that is going to take quite a bit more research, and one of the next steps with that would be to go and reproduce the Q-sort methodology with supervisors, with counselors, with graduate students, and then move on to doing a Delphi study of an expert panel to develop some of those competencies. So I want to thank you all for participating in this. I will be at the ACES conference next week, or I say next week, it's actually tomorrow. So for those of you who will be there, I welcome you to get in contact with me if you would like to discuss this further. I will be presenting on the topic there as well. So I look forward to any future discussions. If anybody would like to have a copy of my dissertation results, please email me. My email is here and will be included in the slide deck as well. So I welcome anybody to get in contact and continue this discussion further. And then I know we have just a few minutes for any follow-up questions.
Great. Thank you so much, Dr. Avery. Thank you for bringing us this really important bit of information and also about your dissertation. It's very fascinating. We do have a few questions coming in and some from some friends of ours. We also had a number of people reacting to your statement early on about the minimal requirement for addictions information. So we had a number of people respond to that. And Elizabeth also asked about, she says in the 2009 CACREP standards, there were several trauma-related standards for campus personnel in CCSA, responding to disasters, assessing student needs. Any insight into why they disappeared for 2016? Is that something that you can speak to?
You know, that's not something I was able to find a lot of information on as to what some of the justifications were of moving from some of the wording in the 2009 to the 2016 CACREP standards. So if anybody has additional information on that, I would love to for you to get in touch and share that.
Okay, thank you. And as a follow-up question also, are there texts or recent articles you would recommend for use in a course?
Yes. So the SAMHSA quick guides, I think are great entry level. If you're just doing like a one-off class or the start of a trauma-specific course. I have quite an extensive resource list, so please email me if you have any specifically focused areas, and I'm happy to send you references for articles. So I think it's important to include articles related to, there's one from Cook et al. On how chronic and developmental trauma impacts children. That's one I've used, and it's a very approachable article for the graduate level, as well as articles on the social and historical context of trauma, looking at systemic racism and things like that are often aspects that aren't broadly covered within the textbooks. So those would be good supplemental articles.
All right, thank you. And Donald, as a follow-up, mentions that in the October Counseling Today, there's several trauma-related articles, which may be excellent to use for coursework as well.
Yeah, the exciting part is that this is gathering increasing focus. So I think there's a wave coming about of looking at this not just as a postgraduate specialization area, but how do we bring it into the base level knowledge that we're working with counselors at the training level. So there's keep up to date on the latest research. There's stuff coming out every month.
Sure, thank you. Thomas is asking, when providing instruction, do you discuss triggering for students as they study both within and outside the classroom?
Yeah, that's a great question. There's a lot of research out there on being a trauma-informed educator, so how to work in a trauma-informed classroom. I introduce my students from that first semester within the program of the archetype of the wounded healer, to both normalize the fact that many of our students come in with trauma experiences. It's part of what has drawn them to this field, and encouraging them to develop the self-awareness to know when that is impeding their ability to be effective and when they can use it as a strength for themselves of having that experience to be able to empathize with clients and pay attention. So taking it more from the sort of trigger warning that gets put on syllabus into more of that comprehensive contextual discussion of how do you develop the self-awareness, how is this part of your identity development as a counselor.
Mhm.
Yeah, great question.
All right, thank you. And Thomas, thanks you as well for your response. Shannon mentions that she uses the SAMHSA Tip 57 as required reading for the
Oh,
trauma course.
awesome. Yes.
And also that there's a trauma competency and active ingredients approach for treating post-traumatic stress disorder by Gentry et al. And that looks like
Hmm.
it's a recent article too. So just as you said, it seems like there's becoming more exposure into this very important field.
Yeah, Gentry has written extensively on trauma practice, so that would be a great resource as well.
Okay, great. Well, thank you. We may need to have that be the last comment as we are at the top of the hour. Oh, all right. I'll do one more. Donald's asking about recommended resources for compassion fatigue. I think that's an important one.
Oh, yes. Gosh, I mean, if you're going to really some of the emerging, um, the first place to look is Figley, who did that initial work. Um, I think it's important to distinguish the differences between compassion fatigue and secondary traumatic stress and vicarious trauma. So I have quite a few resources. If you want to email me, I'm happy to share some of those with you.
Okay, thank you. And that really does need to be the end. We are at the top of the hour. There were other questions that we were not able to get to. So, as Dr. Avery said, your slide deck will have her contact information. So, she has welcomed your correspondence, and she'll also be at the ACES convention starting tomorrow. So, you do have a trip ahead of you. So, I want to say thank you very much for your time, Dr. Avery. Thank you also to our audience members for attending. And we look forward to seeing you again very soon.
Thank you, everyone.